In open-heart surgery, the critical cannulation phase is the precise window where seconds determine the patient's stability. During these minutes, the scrub nurse acts as the primary safety controller for the sterile field. You are managing the physical integrity of the circuit before the patient is ever connected to the machine. Your focus is on preventing 4 specific complications: air embolisms, circuit clotting, incorrect cannula sizing, and wrong line connections. We will walk through the specific steps of this sequence, beginning with the immediate aftermath of the sternotomy and ending with the start of full bypass. Standardizing your table preparation and maintaining closed-loop communication ensures the surgical team maintains technical control throughout the procedure. Step 1. As soon as the median sternotomy is complete, your table management must shift. The priority moves from basic tissue retraction to vascular exposure and immediate hemostasis. Next, the surgeon opens the pericardium. Be ready with stay sutures to suspend the pericardial edges, which provides the necessary exposure and protects the heart from accidental contact. This layout shows a sterile Mayo stand with a clear boundary. A sterile towel separates your cutting instruments, like scissors and heavy forceps, from the specialized tubing and clamps in the cannulation zone. The first requirement before any cannula enters the heart is confirming systemic anticoagulation. This flowchart tracks the hard stop protocol. You must mentally pause to verify the activated clotting time, or ACT, measuring blood clotting time on heparin. Never pass the first instrument until the surgeon announces heparin in, and anesthesia confirms the target ACT. Enforcing this pause ensures the bypass circuit does not clot the moment blood begins to circulate. Step 2. Physical preparation begins with the aortic cannula. This tube will carry oxygenated blood from the machine back into the patient's systemic circulation. Hand the instruments in the surgeon's preferred order, typically pledgeted sutures, followed by needle holders and forceps. This minimizes the time the ascending aorta is open and bleeding. As shown here, forcefully flush the wire-reinforced cannula with saline. This clears all air bubbles, the only way to prevent a catastrophic air embolism. Next, we prepare the venous side. This diagram compares a single right atrial cannula to a bicaval setup, entering the superior and inferior vena cava. For bicaval setups, prepare connectors, tourniquets, and umbilical tapes, which cinch the vessel walls tightly around the venous lines. On the venous side, a loose connection will draw air into the tubing. This destabilizes venous return to the pump and can cause the bypass flow to stop entirely. Rigorous de-airing and secure connections on both the arterial and venous lines provide the technical foundation for a safe transition to the machine. Step 3. This is the sterile handshake. You are passing the ends of the sterile lines to the perfusionist, who manages the unsterile bypass machine. You must maintain a strict physical boundary here. Do not allow the perfusionist's unsterile hands or the non-sterile circuit components to cross the edge of the surgical drape. Manage line clamps with discipline. Move clamps only under direct verbal orders from the surgeon or perfusionist. Use closed-loop communication to confirm the state of the lines. State clearly, arterial and venous lines connected and secured. As the patient goes on pump, monitor the cannulation sites. Have suction and sponges ready to manage any immediate bleeding. The final preparation in this sequence is the cardioplegia line. This delivers a potassium-rich solution into the aortic root to intentionally stop the heart and protect the muscle during the repair. Always keep the cardioplegia line physically distinct from your suction and vent lines to prevent any accidental cross-connection. Managing these connections ensures the heart can be safely arrested, allowing the surgical repair to begin. The workflow is complete, the patient is stable on bypass, and the operative field is prepared for the main procedure. Review the technical requirements. Verify heparin and ACT. Flush all air from the cannulas. Secure every connection. Maintain line clarity, and keep hemostasis tools ready. Following this structured sequence ensures that every member of the surgical team, regardless of their individual experience, adheres to the same safety standard. Save this guide and use these specific parameters to standardize the cannulation training for your cardiac OR team. When you lead the field with technical discipline, you ensure the integrity of the operation and the safety of the patient.